My name is John Grainger. I'm a paediatric haematologist up in Manchester, and thank you to Mervyn and the organisers for inviting me to give an update on the Paediatric Registry, which is fully supported by the ITP Support Association, and now coming on towards 15 years. So the Paediatric Registry was initially formulated in 2007. And we run as initial pilot here in the Northwest before launching nationally in 2008. Over the years, we've added in important bits. We've added in quality of life work in 2010, which has been very important. We got support from the research network of paediatric research teams back in sort of 2013, which allowed us to expand to a greater number of sites, and in particular a lot more of the local sites, which would see a lot of the more general paediatric cases. In 2014, as some of the newer drugs started to come through, we again sort of expanded our registry to include those patients with persistent and chronic ITP who hadn't previously been sort of enrolled, and also expanded a number of side studies to look at side effects of treatment, patient self-reporting of bleeding. We had then also sort of in 2019 and only recently completed earlier this year underwent a major update of our IT systems, funded by some charitable funding from a patient's family. And of course, in 2020, we had the impact of COVID, which was a learning experience for us, and I'll show some slides of that as well. So the recruitment of the ITP registry, as I say, from the humble beginnings back in sort of 2007, when we were just recruiting our Manchester patients, it was around 50. We reached a peak of just under 300 patients, which probably represented about 3/4 of the patients with ITP in the country in 2016. I then have stayed at around the 250 mark. Unfortunately, during the COVID sort of pandemic, research studies other than those focusing on the intervention of treatments for COVID were largely pulled, and our recruitment fell to around 50. It's now back up at around the 100 to 150 mark and growing. One of the first pieces of work we did was to look at what proportion of children have sort of bleeding severity, or what bleeding severity and what their sort of platelet counts are. So in the beginning in 2007, we demonstrated that just over half of our patients sort of had mild bleeding severity, had an average platelet count of sort of 13 to 14, and had a small number of bleeding sites, with thankfully the vast majority of them avoiding treatment. The other half of the patients were largely patients with moderate bleeding severity. They tended to have a lower platelet count and an increased number of bleeding sites, with about 1/4 of them receiving intervention to boost the platelet count. Children with severe bleeding has been consistent in our registry and other registries as between 3 and 5%. Again, lower platelet count still, although most children with these counts will still be in the mild spectrum. Again, increased number of bleeding sites, and the majority of these children receiving prompt intervention. Again, ideally this number should be up at 100%, and we're continuing to provide education, and the consensus guidelines which we have been involved with again have emphasised the need for prompt treatment of children with significant bleeding. Looking at the children with that moderate, which as I say about 1/4 of them are currently being treated, again we found that the most significant factor that would drive treatment was the number of bleeding sites, and that the platelet count didn't seem to drive that. When we've looked at our registry data to look at what treatments people are receiving, we can see that in those children who received no therapy, the average platelet count at the time of presentation was 13. That rose to a safe level of around the 50 mark by around sort of day 7. Those who received sort of steroids, It was a little bit quicker, probably hitting that 50 mark a couple of days earlier, but those who received immunoglobulin, it was hitting that sort of safe level of over 50 very quickly. It was also noted by us and by other groups that those children who received immunoglobulin appear to have a much higher platelet count even 3 months after initial presentation. That work led on to an international study to see if upfront use of immunoglobulin could reduce the incidence of chronic ITP. So there was this lovely study performed in the Netherlands which took newly diagnosed patients with ITP who had mild or moderate bleeding but no severe bleeding, and they were randomized between observation and upfront immunoglobulin. In summary, there was no difference between the children who went on to develop ITP, 10% in both groups, although immunoglobulin did increase the likelihood of having a platelet count over 100 up to 3 months, but thereafter there was no difference. The most interesting finding from this study, in my perspective, was that 8 patients in the monitor arm subsequently went on to need rescue therapy for severe bleeding, compared to only 1 in the immunoglobulin arm. And when we look at that in more detail, those 8 patients, 7 out of 8 of them had moderate bleeding at the time of presentation. This compared to 6 patients in the immunoglobulin arm needing a short duration admission due to immunoglobulin related side effects such as fever or headache. Based on this study, in the international consensus recommendation, we recommended that those children with active mucosal bleeding should receive therapy, most likely to receive immunoglobulin to try and reduce their risk of future severe bleeding. When we analysed our UK data, we analysed patients with nosebleeds, which is the most common site of mucosal bleeding. For children who had nosebleeds of under 30 minutes duration, we found no subsequent increased risk of severe bleeding. However, those who had a nosebleed going on for 30 minutes or more had a 4-fold increased risk of a subsequent severe bleeding. And this paper which we have written is currently in press and awaiting final publication. Moving on to sort of children with persistent and chronic ITP. Once the ITP has been going on for 6 months, only 25% of children are going to spontaneously improve in the next 6 months. And once ITP has been going on for over 12 months, only 10 to 20% will resolve in the next 12 months, and again subsequently. So these children with active ongoing ITP, especially those who have a platelet count below 20 to 30, remain on ongoing risk of bleeding. They'll be facing lifestyle restrictions and will have reduced quality of life. As such, we recommended in the consensus recommendations that such patients were more likely to benefit from treatment. We also made a recommendation around sports and play, so that children should be in continued normal attendance at nursery, school or college. We recommended that there should be ongoing adherence to national activity requirements, but obviously we should be promoting more lower risk activities, and high risk activities would generally be discouraged, or treatment given to boost the platelet count to a safe level so such activities could be enjoyed safely. When we look at sort of our UK data of what patients are sort of receiving sort of treatment, we saw that of analysing those patients who would be eligible for treatment, i.e. had a platelet count of under 30 at 6 months, that sort of only 23% of patients were receiving second line therapy. That was most likely to be sort of the TPO receptor agonists such as eltrombopag or romiflostin, followed by rituximab or other immunosuppressants. What we have seen over the years is a reduction in the time to receiving second line therapy from 41 months back 5 years ago to about 12 months more recently. However, we have not seen an increased frequency in those children receiving second line therapy. Certainly it is our normal clinical practice to discuss treatment options with all these families at 6 months and then allow it to be a family decision based on bleeding problems and also balancing that with the burden of treatment and more frequent hospital visits potentially. This is data that we have done from one of our medical students last year, looking at the impact of COVID on paediatric cases. We postulated that the COVID pandemic would potentially increase the number of cases. Here we can see sort of the instance of cases over the seasons, and here we can see when we had the first lockdown and the second lockdown. What's quite clear is that as the first lockdown kicked in, we saw a reduction in the number of cases, which then gradually increased, and then there was a further dip here around the second lockdown, followed by another surge in cases as we came out of lockdown. This again supports the hypothesis that in children, most of our paediatric cases are triggered by infection, so that when we were in the lockdown, there was less exposure to viral infections as there was reduced social mixing between children. We also saw that the pre-viral trigger of ITP dropped from a historic about 57% of our cases on the registry to 29% of cases. So the cases also that we were seeing were less commonly linked in with infections, although clearly there was more social mixing going on. We also noticed that there was an increased frequency of children receiving treatments who did present with ITP, up to about 25% from our historical sort of 13%, with again treatment more likely to be immunoglobulin, suggesting that people had an increased concern about ITP during the COVID pandemic, and obviously a concern about using steroids, which initially we didn't know if that could increase risk of a more significant COVID course or more likely to contract COVID. Currently, we're still sort of continuing to explore the impact of COVID. We're seeing a lot more cases now of COVID-related ITP now that we're out of all of the lockdowns, and especially with the new Omicron variant as it spreads through schools. We've also sort of been exploring and writing up our experience of the combination of rituximab and dexamethasone for treatment of chronic ITP, especially in adolescent girls. One of our students is currently working with me over the last couple of weeks, looking at markers of alternative diagnosis of ITP. And again, we're continuing to explore and work with families to look at the impact of sport and play on ITP outcomes. So thank you. That concludes my talk, and I look forward to taking a few questions later.